Our motto is that yes, it's possible.
For our patients, it's not just being able to survive, but also being able to live.
In order to help cure cancer, sure, there are a lot of hurdles, but we can overcome those hurdles. This is a 70-year-old African-American female, and when she was in the ER, they got a chest x-ray, showed a left upper lobe lung mass. She has a history of a stroke in 2008.
Here at Hopkins, we are given the most challenging cases. And Dr. Yang is particularly interested in high-risk patients.
So do you want to biopsy the mediastinal node?
The research that Dr. Yang is doing now gives patients lots of hope.
So what I'm working right now is looking at outcomes in the older patients on whether there's a difference between minimally invasive surgery versus an open operation to see if...
Many times patients that have small cell lung cancer think of it as being a death sentence. But Dr. Yang is realizing that some patients can do very well with surgery. He's able to see and do things in the operating room that other people aren't able to do. 968A.
Dr. Brock's work is focused mainly on DNA, the basis of life, and trying to figure out why patients get cancer, why some genes turn on and turn into cancer, and whether we can turn some of these genes off to make them more susceptible to chemotherapy.
We can hit the actual cell that might be causing metastasis, then the options for other therapies then go up exponentially, including surgery.
I think Dr. Brock is challenging the current wisdom by his unique approaches in trying to figure out why patients have cancer. I think he's on the threshold of figuring out why patients recur after cancer.
We are realizing that these epigenetic markers may tell us specifically what patients we can target for cancer therapy.
Dr. Brock is always thinking what's new and innovative, and how are we going to apply this to a clinical setting? How are we going to help patients with this? And how is this going to change, how medicine is going to be practiced?
So you just need to go through these here, right? What's different about Hopkins is that a lot of people are physician scientists here who have one foot in the clinic and one foot in the science, and so we're able to move things forward very quickly.
This is a 76-year-old Chinese-born gentleman who...
Tumor Board is our weekly meeting where all the surgeons and oncologists and members of those teams get together and discuss our patients.
Is there something real on the CAT scan in that left island?
It's tough to do bilobectomy on that, but...
Well, esophageal cancer is going to make it much more complicated.
At Johns Hopkins, we have a team approach for basically everything.
So that's what we're arguing.
We evaluate, is this the right plan? This is where you come to get complete care.
Is surgery the right option for this guy?
And EUS is probably the best way to go, yeah.
I mean, nobody is disagreeing he needs a EGD, but the question is, what's the upper lobe?
We are aggressive for patients to get the best outcome possible. The patient needs to know going into surgery that there is hope. We're doing this for a chance of cure.
I think one of the stigmas of cancer is that people think it has such a negative connotation, and one of the things that we've been trying to do is make it more positive. People do survive, and the outcomes are excellent. We're constantly trying to do better. We're constantly trying to figure out, how can we make these therapies applicable to more and more patients. That's been part of our culture here for over a century now, is the innovation. It's in our blood here to be on the cutting edge. We give the best treatment. We want to be great innovators, so as the next generation moves on, they're going to do something better. We always will come up with new and exciting ideas, and therefore patients will always have the hope that a cure or a new discovery is right around the corner.